In this session we will discuss a few acid-base disorders, with the aid of a graph. We can graph the relation between the pH and the pCO2 on a Cartesian diagram, in the setting of the four simple acid-base disorders. In the left upper frame, we can identify respiratory alkalosis, as the pCO2 is lower than normal, and the pH is accordingly higher than normal. In the right upper frame, there comes a metabolic alkalosis. Both the pH and the pCO2 are high, due to elevated bicarbonate levels. In the right lower frame, you see a respiratory acidosis. The pCO2 is primarily high, thus lowering the pH. Finally, in the left lower frame, there is metabolic acidosis, due to low bicarbonate levels, yielding low pH and compensatory low pCO2. Here you can see the whole frame, with depiction of the function of the four disorders, including acute and chronic respiratory disorders. Now, let's move to a few common clinical scenarios. A patient develops acutely decompensated heart failure, yielding an increased respiratory rate, that lowers the pCO2 and increases the pH. The initial acid-base disorder is therefore a respiratory alkalosis. pH is 7.5 and pCO2 is around 31. The graph helps identifying the presence of compensation, without further calculation. In time, some respiratory muscle fatigue develops, and lactic acid released by the diaphragm pushes down the pH. Eventually, the respiratory rate restores to normal values, and lactic acidosis is the only disorder left. Please notice that there is now high anion gap metabolic acidosis, due to the depletion of bicarbonate, which is now replaced by the lactate anion. Case number 2. Patients suffering from chronic obstructive pulmonary disease, i.e., COPD, are usually hypoxic and hypercapnic, and their arterial blood pH is accordingly low. But not too low. Thanks to the kidneys. A superimposed pulmonary embolism may however increase their respiratory rate, yielding a normalization of their pCO2 and pH, so that the initial presentation is that of a dyspneic patient with clear lung fields, and no apparent acid-base disorder. Misinterpretation of the clinical scenario may also lead to unnecessary diuretic therapy, yielding a mixed alkalosis, both respiratory due to PE, and metabolic due to reduced extracellular fluid volume. A thorough examination of the ABG at presentation would have highlighted reduced P to F ratio, and increased alveolar arteriolar gradient, unmasking the underlying pathologic condition. Okay, let's now consider a metabolic acidosis due to diabetic ketoacidosis. The elevation in Ag, i.e., anion gap, results from the conjugate anions of the keto acids. If left untreated, this condition can lead to severe vomiting, yielding a loss of hydrogen ions and a reduction of the extracellular fluid volume, thus causing a concomitant metabolic alkalosis, which normalizes the pH, bicarbonate, and pCO2. On the other hand, the Ag keeps rising, as conjugate anions from keto acids dissociation accumulate. This guy here is affected by an acute kidney failure, due to ascending urinary tract infection. His blood gas analysis shows metabolic acidosis with compensation, and a normal Ag, due to bicarbonate loss from the kidneys. Bicarbonate is here replaced by chloride ion. After a while though, the infection turns into sepsis, and a respiratory alkalosis adds on, due to the impact of bacterial endotoxins on respiratory system. pH is less altered, but pCO2 is more reduced, due to the additional stimulation of respiratory centers. The fifth scenario concerns a patient suffering from COPD, whose baseline pH and pCO2 are typically altered, as depicted on the graph. During the exacerbation of the disease, the point of intersection of the pH and pCO2 values falls in between the respective curves of chronic respiratory acidosis and acute respiratory acidosis. The hypercompensation in acid-base balance, during exacerbated COPD, is caused by a faster response of the chronically compensating healthy kidneys. As the exacerbation worsens, however, the pH will drop to a critical level, due to the severe increase of the PCO2. The new scenario warrants intubation and mechanical ventilation, to re-establish safe conditions for the patient. As the PCO2 slowly clears up, the pH rapidly increases, thanks to the ongoing kidney compensation. Consequently, if you aim at a quasi-normal PCO2, there will be an out-of-proportion elevation of the pH, which translates into metabolic alkalosis, aka post-hypercapnic alkalosis. To avoid it, mechanical ventilation should aim at restoring the baseline PCO2 value. A variation of the former scenario concerns a patient with acute respiratory acidosis and metabolic acidosis due to the underlying chronic kidney failure. In this setting, the pH gets lower than expected in case of hypercapnic respiratory failure, because the kidneys are failing to compensate properly. The very low pH, less than 7.15, warrants intubation and mechanical ventilation, despite PCO2 less than 80. While the PCO2 lowers and the pH increases, physicians buy time to prepare for dialysis. Mechanical ventilation and dialysis will eventually restore the initial status. In the last scenario, we will discuss a triple acid-base disorder. A 14-year-old girl with bulimia was brought to the ER after being found unresponsive at home, with an empty pill bottle nearby. The graph easily allows for recognition of the following two acid-base disorders: metabolic acidosis and respiratory alkalosis. Further inspection of the ABG revealed elevated anion gap, with the delta anion gap significantly higher than the delta bicarbonate, i.e., delta ratio greater than 2. So, metabolic alkalosis must have coexisted. Lab tests turned positive for aspirin in blood, and a chest X-ray showed aspiration pneumonia. Taken all together, those findings are consistent with aspirin poisoning, which led to increased respiratory rate by a direct stimulation of the respiratory centers, and persistent vomiting, with aspiration pneumonia yielding hypoxia-induced hyperventilation.